You know those days. Your legs just feel heavy, tired, maybe they ache or throb after you've been on your feet, or even just sitting too long.
Yeah. Or maybe you've started seeing some like twisty, bumpy veins pop up that weren't there before.
Honestly, that.
That feeling, those changes, they're incredibly common. Really, it affects a huge number of adults.
Right.
And while, sometimes those visible veins are just a cosmetic thing, for
Mhm.
lots of people, it's actually a sign of something more.
Something medical.
Yes, a medical condition that can um, progress and really impact how your legs feel and, well, how they function.
And that condition is chronic venous disease of the lower limbs.
Hmm.
Basically, a problem with the plumbing, the veins in your legs.
That's it. It's a major health topic, really, just because of how many people it touches and the range of issues it causes, from just mild discomfort all the way to serious skin problems. Understanding it is key.
Which is exactly why we're doing this deep dive. We've been digging into a really significant source, the absolute latest guidelines from the European Society for Vascular Surgery.
Yeah, this is basically the collected wisdom of a huge group of experts. You've got vascular surgeons, dermatologists, radiologists.
Even specialists who understand things like pregnancy and how that affects veins.
And what's really great is that they actually involved patients in creating these guidelines.
Oh, that's good, to make sure it's understandable.
Exactly. Not just medically spot on, but relevant to people actually, living with it. We're relying completely on their expert work today.
So our mission here is simple. We want to take this really comprehensive expert document, kind of cut through the jargon,
Hmm.
and pull out the most important bits for you.
Right.
What this disease actually is, how it happens, how doctors figure out what's going on.
And the treatments,
Mm-hmm.
the whole range from simple self-care stuff to, more advanced procedures.
Right. We want you to finish listening feeling genuinely well-informed about this, about chronic venous disease and what managing vein health looks like.
Okay, so let's start with the basics. Healthy veins in your legs. Picture them like a low-pressure highway system. Their job, get blood back up to your heart.
Against gravity, which is the tricky part.
Right. And they have these amazing little one-way valves inside, like tiny trapdoors. They open, let blood flow up, then snap shut so it doesn't fall back down.
Clutter.
And there's more. Every time you use your calf muscles, like when you walk, they squeeze the deep veins. It acts like a pump, pushing the blood upwards.
Like squeezing a tube of toothpaste, maybe?
Exactly like that. It's called the muscle pump. So that's the healthy setup.
Okay, sounds pretty efficient. So what goes wrong?
Yeah.
What causes chronic venous disease?
Well, there are basically two main culprits. The first one, and probably the most common, is called reflux.
Reflux. Like acid reflux, but in your veins.
Sort of, yeah. It's when those one-way valves get weak or damaged, maybe stretched out. They just don't close properly anymore.
Ah, so the trapdoor is leaky.
Precisely. Blood trickles, or sometimes really flows backward, and it starts pooling in the lower part of the vein, especially, when you're standing or sitting.
Got it. Leaky valves causing backflow. What's the second main problem?
The second one is obstruction. Think of it like a blockage or a traffic jam in the vein highway.
Okay. What causes that?
It could be scar tissue left behind after a blood clot, narrowing the vein. Or sometimes something outside the vein, maybe deeper in the abdomen, is pressing on it and squashing it.
So leaky valves or traffic jams. And both of those lead to what?
They both lead to the same fundamental issue. Yeah. Increased pressure inside the veins, especially in the lower leg when you're upright.
High pressure.
Yeah, chronic high pressure, sometimes called venous hypertension. That high pressure is really the root cause of almost everything else. The symptoms, the visible changes, all of it.
And I gather this isn't something that just pops up overnight. It usually develops over time, right? I think the guidelines mention stages.
They do, yes. They use a classification system, basically a way for doctors to describe how severe it is. It goes from, C0 right up to C6.
C is 0. What's that?
That's where it can start really subtly.
Yeah.
You might just have symptoms like that aching, heaviness, tired legs thing we talked about, but zero visible signs on your legs.
Wow. Okay. So you can feel it even if you can't see anything wrong. That's important.
Absolutely. That's C0SS for symptomatic. Then, as it progresses, you start getting visible signs.
Like the spider veins.
Exactly. C1 is those tiny web-like veins, often red or blue, near the surface, reticular veins, or telangiectasias, people often call them spider veins. And then C2 is when you get the bigger, bulging, twisty ones, the classic varicose veins.
Okay, C0 is symptoms only, C1 spider veins, C2 varicose veins. What's next?
C3 is swelling, edema. That high pressure starts making fluid leak out of the tiny blood vessels into the surrounding tissues. Your legs, your ankles, they start to swell up.
Right, the pressure is literally pushing fluid out.
And if that high pressure keeps going, it starts damaging the skin itself, especially around the ankle area. That's C4.
Oh, kind of damage.
You can get skin changes. Things like brownish staining, that's called pigmentation. The skin can get really hard, thicken, tough.
You mentioned like old leather before.
Yeah, that's a good way to picture it. That hardening is called induration or lipodermatosclerosis. You might also get redness, inflammation, itching, eczema. That's all under C4.
Sounds pretty unpleasant. And the final stages?
Well, C6 is the most advanced. Because the skin is so unhealthy from that chronic high pressure, even a small knock or scratch can break it down and form an open sore, a venous leg ulcer.
Ouch. Painful and hard to heal, I imagine.
Very much so. And C5 is when you've had an ulcer, but it's healed up, leaving a scar. It shows the disease reached that severe stage before.
So it's a whole progression. Starts subtly, can end up with these really difficult skin problems.
Yeah.
And you mentioned different types of veins can be involved.
Yes, and that's really crucial for deciding on treatment. The problem could be mainly in the superficial veins, the ones closer to the skin, like the saphenous veins that often become varicose.
The ones you can often see.
Right. Or it could be in the deep veins, which are buried deep inside the muscles. They carry most of the blood back, so they're essential.
And there's a third type.
Yeah, perforating veins. These are smaller veins that connect the superficial system to the deep system. They can develop leaky valves too. Knowing which system, superficial, deep, or perforator has the problem is key.
Okay, we've got the mechanics down, how the plumbing works, how it breaks, how it progresses. So putting it all together, what does it actually feel like for someone and look like?
It's really varied, and this is a key point from the guidelines. Your symptoms don't always match the signs.
How so?
You could have really prominent varicose veins, like really visible C2 changes, but feel hardly any discomfort. Or, conversely, you could be in that C0 stage legs, feel awful, heavy, achy, but look perfectly normal.
So don't ignore how your legs feel just because they look okay.
Absolutely not. But the classic symptoms, that feeling of heaviness, tiredness, like your legs are just dragging, a sensation of swelling, even if it's not super obvious. Itching is common too.
What about pain?
Yeah, things like nighttime leg cramps can be related, a throbbing or burning feeling, just a general ache. And crucially, these symptoms often get worse after you've been standing or sitting still for a long time.
Because gravity's winning.
Exactly. That impaired blood flow struggles even more.
Is there a specific type of pain linked to exercise?
Yes, something called venous claudication. This is different from typical muscle soreness. It's pain, usually in the calf, that comes on during exercise, like walking, and then eases off pretty quickly when you stop.
What causes that?
It's caused by severe obstruction, usually in the deep veins. When you exercise, your muscles need more blood flow out. If there's a major blockage, the blood can't get out efficiently, pressure builds up rapidly, and it causes pain.
Okay, so pain from blood getting trapped during exercise. Are there any sudden acute problems we should know about?
They're less common, thankfully, but yes. Sometimes a varicose vein near the surface, if it's very thin-walled, can get knocked and bleed quite suddenly. That needs pressure and attention right away.
Scary.
And you can also get a blood clot forming in a superficial vein, superficial venous thrombosis. It's usually painful, red, and hard along the vein. Needs checking out, though generally less dangerous than a deep vein clot.
Okay, so if someone's experiencing these things, how do doctors actually see inside? How do they know for sure what's going on with those valves and blockages?
The number one tool, really the gold standard according to the guidelines, is ultrasound, specifically duplex ultrasound.
Ultrasound, using sound waves to make pictures, right. How does that help with veins?
It's brilliant for veins because it doesn't just show the structure like, is the vein open, is it narrow, is there an old clot? It also shows the blood flow in real time.
You can see the blood moving.
Yep. You can see the direction it's going, how fast it's moving. The person doing the scan can do maneuvers like squeezing the calf to see if the valves are holding or if blood flows backward, that reflux we talked about.
Wow, like watching traffic on the vein highway, seeing the jams and the cars going the wrong way.
That's a perfect analogy. It lets them map out exactly where the problems are, leaky valves, blockages, which veins are affected.
Do they ever need to look higher up than the legs?
Sometimes, yes. If the swelling is really bad, or it doesn't quite fit the picture in the legs, or if they suspect a problem higher up, like in the pelvis or abdomen, they might do an ultrasound there too to check the big veins leaving the legs.
Are other scans ever needed?
Occasionally. The guidelines mention things like CT scans or MRI scans, or even a special X-ray with dye called venography might be used for complex cases, maybe planning a tricky deep vein procedure. But for most people, that duplex ultrasound gives all the information needed.
Okay, so ultrasound maps out the problem. Then what? Is it always straight to fixing it with a procedure?
Oh, definitely not. And the guidelines are really clear about this. For many people, particularly in those earlier stages, or even just for managing symptoms, conservative approaches are the first step, and they can make a huge difference.
Conservative meaning non-surgical things.
Exactly. Simple things, lifestyle things, like regular exercise. Especially activities that work your calf muscles, walking is fantastic. Remember that muscle pump. Exercise helps power it.
Squeezing the toothpaste tube.
You got it. Even just doing ankle circles or pointing and flexing your feet while you're sitting can help.
Makes sense. What else?
Elevating your legs, simple gravity, putting your feet up, ideally higher than your heart level when you're resting, helps drain the fluid and reduce that pressure.
Easy enough.
Weight loss is a big one, increasingly recognized as really key, especially with obesity. Extra weight, particularly around the belly, increases pressure on those big veins coming out of the legs. Losing weight can genuinely improve vein function and symptoms.
So weight management is important vein management too.
Definitely. And finally, trying to avoid long stretches of just standing still or sitting still. If your job involves that, try to take frequent breaks, walk around, shift your position, do some ankle pumps, keep things moving.
Good practical advice. Then there's compression, right? That seems like a really core part of managing this.
Absolutely. Compression therapy is probably the single most effective conservative treatment for symptoms and swelling. It's a cornerstone.
How does squeezing the legs from the outside help?
It basically provides external support. It counteracts that high pressure inside the veins, helps push fluid back into circulation, supports the vein walls, and makes that calf muscle pump work even better.
What form does it usually take? Stockings.
Most commonly, yes. Elastic compression stockings or socks. They come in different strengths, different levels of pressure, measured in millimeters of mercury, LMHg.
Is there a recommended strength?
The guidelines suggest at least 15 mmHg for symptom relief, but often something stronger, like 20 to 40 mmHg or even higher, is needed if there's significant swelling, like in C3 or C4.
Are there alternatives to stockings? They can be tough to get on sometimes.
They can. That's a real issue. There are also inelastic options, like special bandages or adjustable wraps, often using Velcro. These don't stretch much, so they provide really firm resistance when your muscles contract. They can be excellent for reducing more severe swelling, and some people find them easier to put on and adjust than super tight stockings.
So options exist, and this compression stuff is proven to work.
Oh yes, strongly recommended in the guidelines. Good evidence shows it helps with pain, heaviness, cramps, aching, and especially swelling. The big challenge, honestly, is getting people to wear them consistently.
Compliance, right?
Exactly. Finding comfortable garments, getting the right size, maybe using aids to help put them on and take them off. That's all really important for making it work long term. There are other things too, like pneumatic compression devices, sleeves that inflate and deflate, but stockings and bandages are the mainstays.
What about pills? Are there medications that can help chronic venous disease?
Yes, there's a category called venoactive drugs. It's important to understand they don't usually fix the underlying leaky valve or blockage.
Okay, so not a cure. What do?
They primarily help with symptoms, things like pain, that heavy leg feeling, the sensation of swelling, nighttime cramps. Some studies suggest they can also help reduce objective swelling, the kind you can actually measure.
Are they safe?
Generally, yes. The guidelines mention they tend to have relatively rare and usually mild side effects. They name a couple, like purified micronized flavonoid fraction, quite a mouthful, and calcium dibisalate, which have decent evidence for helping with symptoms and swelling.
So they could be an add-on to compression and lifestyle changes.
Exactly, especially if symptoms are still bothersome despite those other measures.
Yeah.
Given their good safety profile and relatively low cost, the experts suggest they're a reasonable option to consider for symptom relief and managing swelling.
Okay, so conservative first. Lifestyle, compression, maybe venoactive drugs. But when do you start thinking about procedures? Fixing the actual veins?
Procedures usually come into play when those conservative measures just aren't cutting it. Symptoms are still bad, or the disease is more advanced, maybe C2 varicose veins causing trouble, or definitely if you have skin changes like C4 or ulcers like C6.
And you said earlier the approach depends hugely on which veins are the problem.
Absolutely critical difference. Treating superficial veins versus deep veins is like night and day.
Remind us why.
Because superficial veins, like varicose veins, are essentially redundant routes. You can safely close them off or remove them because the deep veins are there to handle the main job of blood return. But the deep veins, they're the essential highway. You can't just block them off or remove them without causing serious problems.
Got it. Superficial veins are optional extras. Deep veins are the main road.
Hmm.
So for those superficial varicose veins, what are the modern options? I hear it's not the old school vein stripping much anymore.
That's right. The whole field has moved towards minimally invasive techniques done from inside the vein. It's called endovenous treatment.
Endovenous, inside the vein. Like what?
One of the most common is endovenous thermal ablation.
Hmm.
Thermal means heat. They insert a thin catheter, like a tiny tube, into the faulty vein. Then they use either laser energy or radiofrequency energy delivered through the catheter tip to heat the vein wall from the inside.
What does the heat do?
It damages the vein wall, causing it to shrink down and seal shut. The body then gradually absorbs the treated vein over time. It's usually done as an outpatient procedure, often just with local anesthetic.
Heating it closed? What else?
There's cyanoacrylate adhesive closure, basically medical superglue for veins.
Seriously? Glue.
Yep. A special medical-grade adhesive is injected into the vein through a catheter, and it seals the vein shut almost instantly. Studies show it's effective, comparable to the heat methods in many ways.
Okay, heat or glue. Any others?
There's also foam sclerotherapy. Sclerotherapy usually involves injecting a liquid chemical to irritate the vein lining and make it close. With foam, they mix that chemical with air or gas to create a foam, which displaces blood better and can treat larger veins. It's often guided by ultrasound right into the target vein.
Foam to close the vein.
And one more main type is mechanochemical ablation. This uses a combination, a mechanical device, maybe a rotating wire inside the catheter, damages the vein lining, and then a liquid chemical sclerosant is delivered at the same time to ensure closure.
Wow, quite a toolbox. And these are all less invasive than surgery.
Much less invasive than traditional surgical stripping, yes. That's why the guidelines clearly state these endovenous methods are now the preferred first-line approach for treating the main superficial veins, like the great saphenous vein, when they're causing varicose veins or symptoms.
And they're usually done outpatient with local anesthetic.
Often, yes. They frequently use something called tumescent anesthesia.
Tumescent.
It involves injecting quite a large volume of a very dilute local anesthetic solution mixed with saline and sometimes adrenaline into the tissues around the vein being treated.
What's the point of that?
It does several things. It numbs the area completely. It squeezes the vein, making it smaller and easier to treat. And crucially, for the heat methods, it creates a protective heat sink, absorbing excess heat and shielding the surrounding skin and nerves. Using buffered solutions can also make the injection itself less stingy.
That's clever. So these newer methods have replaced surgery.
For treating the main trunk veins, largely yes. The outcomes in terms of quality of life are often similar, or even better. Recovery can be quicker and fewer wound issues. Though, interestingly, how veins might come back can differ. Maybe the treated vein reopens with endovenous methods versus new veins growing after surgery.
Ah, so veins can still come back even after these procedures.
Yes, recurrence is definitely a factor in chronic venous disease. It's a chronic condition after all. Veins might come back because the treated vein didn't fully close or reopened over time, that's recanalization. Or new abnormal veins can develop. Or the underlying disease process just progresses in other veins.
So it's not always a one-and-done fix.
Not always. That's why follow-up is important. And if veins do recur, getting another detailed ultrasound is crucial to figure out why they came back and plan the best approach. Minimally invasive methods are generally preferred for treating recurrent veins, too.
What about the really small ones, the C1 spider veins, or those slightly larger blue reticular veins?
For those, which are often more of a cosmetic concern, the guidelines still consider sclerotherapy injecting a liquid chemical sclerosant as the gold standard. Laser treatments applied through the skin can also be an option, especially for the tiniest red spider veins.
Okay, that covers the superficial system pretty well.
Yeah.
What about the deep veins? You said that's more complex.
Much more complex, and the treatments are usually reserved for more significant problems. Primarily, we're talking about obstruction blockages or severe narrowing in the deep veins.
Often after a blood clot?
Yes. Post-thrombotic syndrome is a major reason. Or sometimes, as we mentioned, external compression of a major vein, like the iliac vein in the pelvis that's called May-Thurner syndrome.
So if there's a blockage in that essential deep system, what's the goal?
The goal is usually to open it up and keep it open, reestablish good flow out of the leg.
How do they do that?
Typically, it involves angioplasty and stenting. Using catheter-based tools, they'll cross the blocked or narrowed segment, often inflate a balloon angioplasty to stretch it open, and then deploy a stent.
A stent, like they use in heart arteries.
Exactly like that concept. A small expandable mesh tube that acts as scaffolding to hold the vein open.
That sounds like a much bigger deal than treating superficial veins.
It absolutely is. These are major procedures, often requiring sedation or general anesthesia, not just local. They carry more risks, and the guidelines emphasize they should ideally be done in specialized centers with experienced teams, vascular surgeons, interventional radiologists working together.
And the results, are they always successful?
It's still an evolving area. Patient selection is really critical figuring out who will truly benefit. And while results can be very good for relieving severe symptoms like pain, swelling, and venous claudication caused by obstruction, more research is needed on long-term stent durability and outcomes.
What about reflux? Leaky valves in the deep veins, can those be fixed?
There are surgical techniques to repair or reconstruct deep vein valves, but the evidence supporting their widespread use is, frankly, less robust compared to treating obstruction or superficial reflux. It's generally considered only in very specific, severe cases.
Okay. And if someone has problems in both superficial and deep veins, what gets treated first?
Doctors have to carefully assess which system seems to be driving the main problem. Often, treating significant superficial vein reflux is the first step. Sometimes, fixing the superficial problem can actually lessen the severity of deep vein reflux, maybe by reducing the overall volume overload on the deep system.
Interesting. So fix the surface roads first, it might help the main highway traffic.
Sometimes, yes, unless there's a really critical blockage in the deep system that needs addressing urgently.
Let's zoom in on those venous leg ulcers, the C6 stage. You said they're tough. What's the absolute key to healing them?
The compression. It is the absolute cornerstone. Without effectively controlling that underlying high venous pressure, the ulcer simply won't heal, or it'll take forever.
So even with an open wound, you still squeeze the leg.
Yes, often with very high levels of compression, using multi-layer bandage systems or specialized adjustable wraps. Sometimes specific stockings can be used over dressings, too. It sounds counterintuitive, maybe, but reducing that pressure is paramount for allowing the skin's healing processes to work.
What else is involved in ulcer care?
Good wound care, of course. Cleaning the ulcer, removing any dead tissue, using appropriate dressings to manage moisture and promote healing. That's vital. But the guidelines make a really crucial point.
Which is?
You need to treat the underlying venous problem at the same time or as soon as possible. Don't just wait for the ulcer to heal with compression alone.
So do the vein procedure, the ablation or whatever, even while the ulcer is still open.
Exactly. Treating the source of the high pressure, whether it's superficial reflux or deep obstruction while the ulcer is active, has been shown to significantly speed up ulcer healing and, very importantly, dramatically reduce the risk of the ulcer coming back later.
That makes so much sense. Fix the plumbing leak that's causing the basement to flood. Don't just keep mopping the floor.
Perfect analogy. It's about addressing the root cause. Additionally, things like exercise, leg elevation, weight loss, and maybe those venoactive drugs can all play a supporting role in ulcer healing too. It really takes a team approach.
You keep mentioning weight loss. Is obesity a particular challenge when it comes to treatment?
It definitely adds complexity. The guidelines reiterate how important weight loss is for improving venous disease outcomes overall. From a procedural standpoint, treatment can be technically harder, and patients with obesity veins might be deeper, access trickier.
But can the treatment still work?
Yes, absolutely. And importantly, the minimally invasive endovenous methods are generally preferred over traditional open surgery in obese patients because there's a lower risk of wound healing problems or infections. Significant improvements in symptoms and quality of life are still very achievable.
Good to know. What about pregnancy? Lots of people notice veins getting worse then.
Very common. Pregnancy involves hormonal changes that relax vein walls, plus the growing uterus increases pressure on the pelvic veins. This can definitely worsen existing vein issues or bring them on.
So what's recommended during pregnancy?
Compression stockings are the mainstay, highly recommended for managing symptoms like aching and swelling and potentially slowing progression during pregnancy. But definitive treatments like ablation or sclerotherapy for varicose veins, those are typically deferred until well after delivery.
Makes sense. Are there other general things to consider in overall care?
Yeah, just thinking holistically. Managing pain effectively is important for quality of life. And addressing any other health conditions someone has like diabetes, heart issues, Mobility problems that could impact their circulation or healing is also part of good comprehensive care.
So we've covered a huge amount of ground here, from understanding how veins work, what goes wrong, the stages, diagnosis, all the way through conservative care, and the different procedures for superficial and deep veins, plus ulcers and special situations.
It's a lot, and it shows how far treatment has come, especially with those minimally invasive options.
But it's also clear, even from these expert guidelines, that there's still things we're learning, right?
Right.
Areas needing more research.
Oh, absolutely. The guidelines are very open about that, which is good science. It shows the field is still evolving.
Like, what kind of questions are still out there?
Well, things like, what's the absolute best technique for different sizes or types of superficial veins? How much do those smaller tributary veins actually improve just by treating the main leaky trunk vein? When and how exactly should we treat those connecting perforator veins?
So, refining the existing treatments.
Exactly. And questions about care after procedures, too. What's the ideal type of compression to wear afterwards, and for how long? What are the best strategies to prevent the small risk of blood clots related to the procedures?
And for the deep vein treatments.
Definitely more research needed there. How do we best select the patients who will get the most benefit from deep vein stenting? How do we measure long-term success reliably? What's the best role for advanced imaging, like CT or MRI venography, especially for planning deep vein work or investigating complex ulcers? Lots of ongoing questions.
It really highlights that while we know so much, medicine is always learning. So, stepping back from all this detail, what's the main message you hope people take away from this deep dive?
I really hope you feel, well, empowered, that you have a clearer picture now of what chronic venous disease actually is, that those tired, heavy legs or visible veins might be more than just cosmetic or getting older.
And that it's a spectrum.
Yes, it progresses, but there are things you can do at every stage. And there's a really wide range of effective treatments available now, from simple compression right through to these advanced, minimally invasive procedures.
Understanding the why behind it all can make a big difference.
It really can. And knowing that treatment isn't, one size fits all. The best approach for you will depend entirely on your specific situation. Which veins are involved, how severe it is, what symptoms bother you most, your overall health, your lifestyle.
Which leads us perfectly into a final thought for you, our listener, to take away and think about. Given that chronic venous disease is so individual, showing up differently, affecting different veins for everyone, how can you use this knowledge you've gained today? How can you partner effectively with your doctor or healthcare team? What questions should you be asking, informed by this deep dive, to make sure your treatment plan is truly tailored to your specific condition, your life, and what you want to achieve? How can you best advocate for your own vein health?
That partnership, built on your understanding, is absolutely key.